Our clinical mentor, Dr. Jennifer Steiman, as a surgeon who trains fellows and med students, often needs to use both hands to hold surgical instruments while instructing. Because of this, she often struggles to effectively communicate where to make incisions, where to suture, cauterize, etc. on patients. One of the devices she wears and utilizes often is a surgical headlamp to illuminate her view. Our clinical mentor was looking for a solution to work in conjunction with her headlamp to point out these regions of interest easily and accurately for the student or fellow without the use of her hands. The solution our group arrived at with our clinical mentor was an addition to the surgical headlamp, which contains a pointer attached to the light for her to point out locations for the student or fellow with accuracy during the surgical procedures, and she can keep her hands in use on the patient. To realize our solution, our prototype is a works-like prototype of a surgical headlamp with our pointer addition. The headlamp unit is comprised of foam core with a foam core box on the anterior portion as a container to hold the cell phone. The flashlight on the cell phone, when inserted, acts as a headlamp light. Attached in front of the light is a translucent green pointer, which is our prototyped solution.
Starting from the headlamp constrained idea, we broke the problem down into its features and functions. We knew that it needed to indicate to a human, so we began populating a solution space with ideas like audio-based interaction, brain-computer interfaces, and visual-based light cues. Though this bred ideas like focusing candlelight through a brain-controlled lens, we eventually settled on additive and subtractive light, such as laser pointers and shaped lens covers. A challenging feature ended up being the requirements for an on-off feature for the indication. We considered how existing tech, such as clap-on lamps, voice control, and foot pedals, might fit the environment. However, our first prototype we settled on ended up being a simple head tilt mechanism. This mechanism is simple and comfortable, and it can be actuated at normal angles of human head travel. Beyond satisfying the obvious requirements, it would also forgo the need for batteries, resist surgical splatter observed in the OR, and unobtrusively fit the form factor of most headlamps. It owes that adaptability to its compact nature, allowing for it to be implemented in real terms as a 1-inch clip-on lens cover for the 1-inch diameter ends to all of the headlamps that we were able to find in our research.
We presented our first prototype to our clinical mentor over Zoom, a week after shadowing her performing a surgery while teaching her fellows and/or students. While somewhat difficult to show the functionality of the prototype over a video call, we were able to accompany the demonstration with reference photos and well-worded explanations. Our mentor gave us almost entirely positive feedback. Her initial question was whether or not she would be required to keep her head tilted while using the prototype, but through our demonstration was shown that it would remain on until tilted back. We had created a 3D model of what the actual prototype might look like, a small cap that would fit on the end of the headlamp. Due to its small size and simplistic design, it would also be fairly cheap to produce. Our mentor responded to this positively, exclaiming that it was a great idea to not add any extra hardware or weight if not needed. Her only concern was that it would remain situated in the lamp during procedures, not falling off or moving. This was noted and will be considered as we move forward with our prototype.
After Dr. Steiman's initial feedback on our first prototype, there remains some small amount of work to do to prove our concept. The information available for the headlamps used by Dr. Steiman did not disclose to us a key point of information. We are unsure of how the light rays exit the headlamp. If the lamp diffuses or scatters the light coming out of the lamp, then the shadow cast by our pointer's edge will not be crisp enough to work as a solution for our clinician. In other words, the pointer's shadow may be too fuzzy to point to small things. This is commonly the case with normal flashlights, in which the light is designed to scatter in order to illuminate more area for the user. However, industrial and medical lamps are designed differently. If the lamp forces all the light to come out in a straight line, as we expect it to, and is high-powered enough, our pointer will have the crisp edge required for indicating very small anatomical features. So the first test for our prototype will not involve our prototype at all. It will actually involve Dr. Steiman using her lamp and creating a shadow with her thumb. If her thumb shadow has a crisp edge, our solution is promising and we can iterate our prototype. If her thumb shadow is fuzzy, then we may need to pivot drastically away from our current prototype's indication mechanism and towards something like a laser pointer. The second test is to bring the prototype, current or new, to Dr. Steiman or an alternative potential user and have them try it with their lamps to gather in-person usage feedback, as opposed to through a virtual interview. We will have to develop a new prototype regardless of whether our pointer method works with their lamps or not, since our current prototype includes a headband and uses our phone's flashlights. This new prototype would clamp directly onto the clinical mentor's lamp and not be a standalone system. Luckily, however, we will not have to test this prototype in an OR, as the OR environment for our purposes can be simulated with room lighting, phone lights to represent other users' headlamps, and a wire or other small object to simulate small physiological landmarks, such as veins or incision locations. The test will have to be carried out in the hospital still, since we will need to use the real headlamp, but we will not have to jump through all the hoops required for getting into the actual operating room again. Afterwards, our test plan will depend on feedback from that session. Either a working prototype can be developed, or another prototype iteration will be made.